Great. So if I can get this. Okay, we're just going to give it a few more seconds and then we will get started. Okay, anybody that joins us now can just pick up right where we are. Welcome to 2024. Hope everybody had good holidays and time off if you got to take time off. And so we're going to do just a couple quick notes just about, I spent some time trying to envision what 2024 for Journal Club should look like. We are, and I see a number of them here, we are really blessed right now within Vivage Beacon to have some incredible medical directors in a broad spectrum of them. And so one of the things that I've asked them to do is throughout the year, I'm going to be involving most of them to do at least part of one of these presentations. And I know there's maybe some stage fright, but all you have to do is listen to me talk for a while and you realize there's no reason to have stage fright. At any rate, so some of those folks are there. Oh, and I saw somebody else I'm going to introduce everybody to that just jumped on the call. I don't know if you can see the participants, but Carl Steinberg just joined us. Carl, can you introduce yourself and just tell everybody just a little bit about yourself?
Yeah, thanks, Greg. Hi, everyone. My name's Carl Steinberg. I'm a geriatrician out in San Diego County, and I'm the chief medical officer for Beacon. I know I've met some of you, and some of you I know better than others. But Greg, thanks for inviting me. And I understand you're going to be on a safari next month, so I'll be happy to give a talk on something next month. And I'm a past president of AMDA. Had the honor and pleasure of being AMDA president in 2021 and 22. It was kind of a rough time, as I'm sure you all remember. So anyway, glad to be off the board now and able to concentrate on other things. So
that's
thanks.
Great. Thank you for joining us, Carl. Yeah, I will be gone next month, and we already have Mike Tobin doing one of the 15-minute segments. He's going to talk to us about some hospice issues. But if you'd like to take the other 15 minutes and just let me know what your topic is, I'd love it. So,
all right, you got it.
Be great. All right. Well, with no further ado, that's going to be part of our year. The other thing is, one of the things I've noticed in the past 4 or 5 months is that we have a whole lot of people that are new to the long-term care space. New meaning they've been at it 3 or 4 years or less. And my memory goes way back to doing this for 12 now, and I think things that were stated in 2014 should be right fresh on everybody's mind, and they're just not. So part of what I'm going to do this year is what we're going to start today is go through Geriatric Pearls, A to Z, things that we can use every day. Some of this will be refresher, some of it will be new, but we're just going to go through the alphabet. And Ashley, here we go. If you can see this, are you able to see my screen? Great. All right. Then we're just going to start with the A's. And so the things I do here as we present are going to be more straightforward, basic, and seldom dig into the weeds. But I'm going to put references with a lot of these things as we go along. And after we get off this call, I will be sending all this out so that if anybody's interested, you can refer back to it or keep it. So the first thing I want to talk about, and some of these you're going to realize are just Dr. Gahm's pet peeves. But the first one here is allergy medicines. We had a wonderful talk just in the past couple of months from Dr. Anneberg, who just joined us, about anticholinergic medications. And one of the things that really has always impressed me since we did this in 2014, believe it or not, when we first started talking about the Magellan anticholinergic risk scale, is that all the different medications that have anticholinergic side effects, synergistically the effects are additive. And so the more anticholinergic medications you use, the more likely you are to have the side effects. So they do add to the anticholinergic burden, which we're going to touch on again briefly. It bothers me that people get put on, whether it's a loratadine or Zyrtec or whatever it is, for seasonal allergies. And then we get to, let's see, it's January in Colorado. We haven't had seasonal allergy here for months, but we still have a ton of people taking these medications every day. One of the things I was taught years ago is not everything that happens that's bad when you age is attributable to aging, but some things are. And one of them is that your medial tear ducts begin to stenose as you age. And as that happens, there are two things that jump out. One is you don't make as many tears across your eyes, so you get dry eyes, and we get everybody, red dry eyes, and we give them their eye drops. But the other thing is that those tears have to go somewhere, and they end up going down the back of your nose. And so you take these folks that have red eyes and a runny nose, and the first thing you jump on is, oh, it must be allergies. So we throw these people on more allergy medicines. It's not always allergies. Okay, that's the first A. The second A, we're going to do 5 A's. We won't have multiple things for every letter, but we do for A. Asthma medication. First thing is that asthma is not COPD and is not treated the same thing. And oftentimes that just gets overlooked, and they both get thrown in the same bucket and both treated the same way, and they shouldn't be. I just sent out a message a couple days ago, same time. I got a list of medications that pharmacies are going to have a hard time filling in the next few months because of more shortages. And the thing that, also last week, the message came out from Glaxo, they're not going to make Flovent anymore. It's not even going to be available. But they are flipping over to their generic steroid, just fluticasone. It'll work just as well. It'll be fine. I don't know when it's going to be available, but I noticed on the list that I sent out with about 15 different meds on it, that about a third of them were all the inhaled medications that included steroids. So I'm not sure I know everything that's going on there, but what I would tell you is to plan ahead. And this is goes back to the whole thing that asthma is not COPD. The GOLD guidelines that we've talked about every couple of years on this call come out, get updated every year. And it's been 4 or 5 years now that they've said inhaled steroids and COPD, just not a high priority. Increases pneumonia, doesn't obviously decrease hospitalizations or improve lung function. If patients need them and they got better, that's fine. Otherwise, they're probably just not necessary. So as we get to this shortage of time, could be really fortuitous to think about just using a LABA or a LAMA and getting rid of the inhaled steroid. The other thing to really talk about is Singular leukotriene inhibitor. I tell people when they ask me about it, it works really well for adolescents with cold or exercise-induced asthma, because it will just block that response, and their breathing is much better. It's not approved for COPD, doesn't work for COPD, and it causes a ton of side effects in older folks, and especially most of those are behavioral and GI. So Singular, just not a great choice in our folks for COPD. Okay. By the way, I'll stop after each of these and see, because I'm talking pretty fast, and I'll just keep talking if I'm not stopped. Any questions, comments about either of these things so far? Okay. Travis, I'll let you watch for chat. If there are questions that come up in the chat, just let me know. I'm easy to interrupt. Next is just a reiteration of what Lee did a couple months ago. Anticholinergic medications, one of the two major classes of drugs that CMS has a real problem with in our patients. So they spend a lot of time in the regs focused on psych meds and anticholinergic meds. We talked a few minutes ago about how their effects are additive as you use multiple agents. If you don't have it, I'm going to send it as an attachment, and I keep this where I can use it all the time. The Magellan Anticholinergic Risk Scale. It is a wonderful reference to look at what it does. It breaks anticholinergic meds down into mild, moderate, and severe, 1, 2, or 3 points. If you get to a level of 3 or higher, it's considered high risk that you're going to have anticholinergic side effects. I went ahead and listed the main ones here. But some of those, we see all the time: hallucinations, agitation, anxiety, things that we just see and then you want to jump on and treat. If you can get rid of medications that have anticholinergic side effects and deal with the problem, it's a whole lot easier than adding benzodiazepines and antipsychotics and just making things worse. So get used to using the Magellan risk scale. It is really useful. And I'm just actually, because I'm talking about it, give me just a second. This is how easy it is for me to get to it. Let me see if I can get to it here. If I can. All right. Hang on 1 second. Here it is. Here it is. I think here it is. There it is. This is what it looks like. So you can see the major medications listed and whether they're 1, 2, or 3 points. So, if you're using scopolamine, or trospium, or hydroxyzine, Benadryl, clozapine, using any of the stuff over here, you're already amitriptyline, you're already at 3 points. So you're already at high risk of anticholinergic side effects. If you've added, Lasix or Dig or Haldol, opiates, quinidine, if you've added muscle relaxants, anything to it, now you're all of a sudden way above 3 and you're getting to higher and higher risk. If you get to, just for fun, at some point in time after you get this, pull out a couple patients that are on 8 or 9 or 10 meds, figure out their risk score, and I think you might be surprised how high they get, how quickly. Okay, enough about that. Let's move on. Let's see, pull that back. Next on the list was appetite stimulants. Not a fan, and you're going to get some of the references I sent you will deal with this that have to do with this. So Megace. First thing to know about Megace is does not lead to increased lean body mass. We're really not interested in weight. What we really want is muscle mass. We don't care how, we don't want to make people fat. If you want to make people fat, let them drink regular Coke, regular Pepsi, soft drinks. There's a great article from about 15 years ago that showed the quickest way to gain weight was to drink regular Coke. And the reason is it's a bunch of calories, but it's liquid, they get absorbed quickly and they disappear, and your stomach never feels, you never get satiety feeling, so you never quit eating, and you can gain weight quickly and it doesn't help. So we don't want to
Greg,
wait. Yeah.
Greg Leonberg here. A couple things to remember about Megace is it turns off testosterone in males. And so males actually get weaker, lose muscle strength, muscle mass when put on it due to their testosterone production going down. Second, it's a prothrombotic drug. So they get pulmonary emboli, stroke, and heart attack risks go up. So there's nothing good about Megace.
Yeah. Well, Lee, I mean, you were a plant in the audience. The 3 references that are on here are the references that discuss those issues, that looked at in a multifaceted thing, looking at gaining strength and so forth in folks. Megace was always at the bottom, caused more harm than good. And everything else you just talked about. It increases, there's a wonderful study that I'll send out that it included, shows that it increases morbidity and mortality in the long-term care population. Very few studies are done in our little neck of the woods, but this is one that came out of geriatric pharmacology from about 2013, 2014. And it actually showed a significant increase, morbidity and mortality. So just not a good drug. Remeron carries that mythical attribute that it gains weight. And actually, if you read the data, and I'm going to send some of it as well, if you don't have depression, Remeron was no better than placebo. If the original population, the control population that you're looking at had depression and you used Remeron at doses that treated the depression and treating the depression worked, if that's the group you're looking at, 1 in 8 persons gained weight, 12%. So it really, I mean, so you can't say it doesn't ever lead to weight gain, 12% if you're using it for depression. But because of that, I don't like seeing it just added for weight gain. And I see a lot of that. Don't buy into it. Don't believe it. You can read the literature if you don't trust me on that. Okay, the last one, Dave Shepard, are you on board? I don't see your name. Dave did a great job a little over a year ago talking about anti-thrombotic, anticoagulant things, aspirin. I'm going to make this one pretty easy. It's been 5 years since the guidelines changed and the data started showing up, showing that even with low dose aspirin, your chance of dying from a GI bleed was higher than your chance of preventing a heart attack or stroke, and not by a little bit. It was significantly higher. So it's been 5 years since the guidelines changed and the recommendations started coming out to quit using low-dose aspirin for primary prevention. Secondary prevention, you've already had a stroke, you've already had a heart attack, it's a different story. You use the low-dose aspirin and all of a sudden, you know, it's more clinically beneficial. I highlighted this USP, United States Preventive Services Task Force, they've got to come up with a better name, recommends against low-dose aspirin for primary prevention of CVD in adults 60 and older. Okay, that's their recommendation. And then I just highlighted some of these others, and I think I'm sending some of these studies to you. What we can conclude about use of aspirin for prophylaxis 150 years after its synthesis, primary prevention, benefits of aspirin. Let's see, that's secondary prevention. Primary prevention, which risk is determined largely by age and absence or presence of diabetes, benefit risk ratio for prophylactic aspirin in practice is really small. So this study from 2018 found there wasn't much there. Higher all-cause mortality among apparently healthy older adults getting aspirin. You can read these. I don't have to read them to you. But in our population today, I would find at least 25 that are on low-dose aspirin. And it usually says heart health, and this gets into the pharmacists tell us this all the time. You know, things like heart health supplement are not diagnoses. You know, we are required to have diagnoses for the medications we use, and heart health is not one of them. If you look in ICD-10, you won't find heart health. So get the diagnosis right, figure out if it's primary or secondary. I think the jury is still out on folks with diabetes. At best, it's equivocal.
And Greg,
might help. Yeah.
Leanneberg again, can you comment on its use for AFib?
Yeah, and that's why I was hoping Dave was here, because he really presented that data well. One of the things that was my single biggest takeaway, he did this April of 2020, April and May of 2022 is when he presented all the anticoagulation, antithrombotic stuff. And my single biggest takeaway after 2 months of this on Journal Club was that Eliquis, the DOAC, at the time, DOACs, Eliquis and Xarelto, were not only more effective in AFib, they were safer, fewer bleeds than with low-dose aspirin, which really caught me off guard. Of course, the second piece of that now that we heard just recently, Xarelto is on the Beers list, but not Eliquis. So I've started gradually transitioning, recommending people to transition from Xarelto to Eliquis. And I honestly can't tell you that I know all the details of that, but it was important enough. It was important enough that they included it in the 2023 Beers update to have Xarelto on that list, but not Xarelto. So yeah, I've moved, Eliquis, if it's more effective and safer, that's where what I'm gonna be recommending instead of aspirin. So I talked pretty fast and there weren't many questions. And that's the end of the A's, by the way. Open this up for discussion on any of this.
Greg, Stan Kirstein.
Yes, Stan.
I've done, when I was in practice, I did a lot of screening for coronary artery calcifications and carotid disease and found many patients who had pretty significant disease. They never had an event. And I've had discussions with cardiologists, and I've never seen anything in the literature about that, but my feeling would be that those patients would benefit by taking an aspirin, because I think that's not going to be primary prevention. They already have disease, but fortunately never had an event. Your thoughts about that?
Yeah, I think that's probably true. And it's interesting because that is a technology that's still trying to get validity to it and get it out there so that more of us will start using it more. And I think once we actually figure that out and get there, I think that's the next group, sort of like diabetics, the next group to look at and say, okay, well, a little heart failure, it didn't work, the aspirin was worse, but what if your calcium score is high, coronary artery calcium score? How about that group? And I think it's worth looking at. I don't know what the answer is going to be. And I don't know what I'd do. I think I'd probably do that shared decision-making model and say, my bias is I think this will help you more than hurt you, but I can't guarantee that. I think with low-dose aspirin, most of us don't see a whole lot of folks with bad GI bleeds. So you fall back on personal evidence. I haven't seen it very much, so it really must not be that evident. I don't know, but obviously if you look at a lot of people in the population, it was statistically there that it was much more likely to bleed than to prevent a heart attack or stroke. So I think they ought to look at it. And right now, I think it'd just be, what are the risks? What are the potential benefits? And where do you want to go?
Yeah, I agree. And that's what I would do. I would tell patients, my bias is to go ahead and take it, but it has not yet been studied, and that there is a risk of bleeding. So, very good.
Others?
Is the anticholinergic score built into PCC at all?
No, it is not. I just keep it on my phone and on my desktop so I can get to it quickly.
Greg, that might be something we want to talk to the consulting pharmacists to see if they can report it out in their monthly medication reviews.
Yeah, I think that's reasonable because as you start, I'm going to pull it up again. You'd be surprised, things like Lasix. I mean, as you start looking through these things, these are drugs we use a lot. And
Right.
Of course, the benzodiazepines, but, Dig, we don't use a lot of anymore, but all the opiates, Prozac,
Prednisone.
Haldol, Lasix, prednisone, Remeron, calcium channel blockers. You start looking at this stuff and realize, gosh, I got a whole lot of people on, multiple drugs from this list.
Yeah, and my
And then you
my
start
take
thinking,
from this is really it's the start of what's called a medication cascade. They start having symptoms, I suspect, due to these combinations of drugs, and they aren't specific symptoms, maybe a little anxious, a little restless, and they start
Right.
a whole cascade of additional drugs, treating
Yeah.
the side effects of the preceding drugs.
right. And actually, if the rest of this handout, the next page, again, talks about the main symptoms. So, and it's got references with it. So it's a nice handout to have, but this is the page I use all the time when I'm trying to figure out those scores. And I think it's sort of like serotonin syndrome. I think it probably happens more often than we recognize, but it's vague enough that we just don't call it what it is and recognize it. Nice question, Mike. So after the email today, you'll have a copy of this at least.
And regarding the aspirin
Anybody
for, aspirin for high coronary artery calcification scores, the American Heart Association does have a stipulation for using aspirin in those situations. So I think there are limited studies that there might be benefit.
Yeah, I guess my problem with that is there is so much specialty bias. I mean, look at PSAs for prostate cancer. What 8 or 10 years ago came out that, hey, don't waste your time, but go talk to a urologist. Man, they're getting them right, left, and center. Don't believe that data and attack it. So I don't know. I'd much rather see this in a neutral setting than coming from a group with a self-interest. I don't know. Maybe they're right. But point well taken. But again, I don't know if that's based on their experience or evidence that maybe, if you see any of that evidence, I'd love to see it. I just haven't seen it.
So Greg, Stanley Kirstein's comments, I thought, were directed more at carotid scores. And because that was something that people in offices, it was being promoted to screen the carotid arteries for obstructions in calcium. And I was a little jaundiced about that because I thought it was, in a sense, being marketed as a way for primary care docs to earn more money by doing studies in their offices. So
Yeah, I don't
sorry
think that's
to
the case.
say that.
Yeah.
Well,
We're
this is
talking about coronary, right?
yeah, this
Right.
is Stan. These are not done in, I'm retired from practice, but these were all done in outpatient settings. And so I would look at both coronary arteries as well as carotids. And if there was significant disease, then I would bring up the aspirin possibility with patients. So these were not studies that were done, at least in my office. We actually did it a long time ago, but it was short-lived. And so these were done in imaging centers, outpatient imaging centers. So to me, it was, vascular disease. And so I would do what Greg had mentioned, is to do just mention to the patients. I personally think this is beneficial. There is a risk of bleeding. There's no data or studies to say it's right or wrong, but my bias is to go ahead and take an aspirin.
Okay, we have about 1 minute left. Any other comments, questions, thoughts? Okay, then I'll just ask, any other, requests for topics that you guys would like to hear over the course of the years? And if you don't have them, you at least get emails from me, so you can always write back and say, tell us about this, or have somebody figure out this. and we could do that. And if there's no more questions and no chat questions, just Happy New Year. And thank you guys again for joining us. And I will see you in 2 months. Thank you.